Welcome to our world.
This is your global.
Introduction. At the heart of everything I do is a simple but powerful belief that if we want to change outcomes for children, we have to start at the very beginning of life. I often say, from the womb to the classroom, but what I really mean is that a child's story starts long before we ever see them in a school setting. It begins in those earliest biological moments that shape who they will become. This work is deeply personal for me. As a mother, I have witnessed both the fragility and the strength of a child's life in ways that changed me forever. My son, S.A.B.R.E.E., experienced serious health challenges early on, including a life-threatening grand mal seizure when he was just 3.5 years old. As a result of his very first seizure, S.A.B.R.E.E. experienced clinical death and prayerfully was resuscitated. Later, he received a diagnosis of Asperger's syndrome, which is on the autism spectrum. And tragically, I lost him and his stepmother, Mrs. Renee Daniel, far too soon. That journey has shaped my purpose in every way. It is why I do this work, and why I am so committed to protecting children and helping families navigate these complexities earlier and more effectively. In collaboration with Akhil Maheshwari MD, a diplomate in nutrition and dietetic, professor of pediatrics, neonatology and founder and CEO of the Global Newborn Society, we are engaging in important conversations about early risk biomarkers and fetal development. Also, about how we can better understand the earliest signals of human health. Because if we can recognize risk earlier, we can respond earlier. And if we can respond earlier, we can change lives. So today, I want to share a perspective that brings together science, lived experience, and a deep commitment to equity, especially for children and families who have too often been left out of these conversations. When we speak of fetal development, we are speaking of the earliest architecture of human life. We are speaking of a period in which biology is not yet fully visible to the eye, but is already extraordinarily active, responsive, and formative. Long before a child enters a classroom, long before symptoms emerge, and often long before disease is ever diagnosed, critical developmental signals are already shaping the trajectory of that child's future health, resilience, vulnerability, and capacity to thrive. For this reason, I believe that the study of early risk biomarkers in fetal development represents one of the most consequential frontiers in modern medicine. From my perspective, early risk biomarkers should not be understood merely as technical indicators or isolated molecular findings. They should be understood as early biological messages. They are signals that may help us detect when development is unfolding optimally, when it is adapting under stress, and when it may be drifting toward increased risk. If we can identify such signals with sufficient rigor, sensitivity, and ethical responsibility, then we have the opportunity to move medicine upstream. We gain the ability not only to react to disease, but to anticipate vulnerability earlier, intervene more wisely, and potentially alter life course outcomes before harm becomes more deeply embedded. This is especially important in fetal development because the intrauterine period is not passive. It is a highly dynamic phase of biological programming. During this time, genetic instruction is interacting continuously with maternal physiology, placental function, nutrition, inflammation, endocrine signaling, stress exposure, environmental toxicants, infection, and social conditions. What emerges from that interplay is not simply fetal growth in the narrow sense, but a developmental pattern that may shape neurological, metabolic, cardiovascular, immunologic, and behavioral outcomes for years to come. In this context, biomarkers are not simply predictive tools. They are windows into the developmental process itself. I believe one of the central scientific opportunities before us is to clarify which biomarkers are most meaningful, at what developmental stages they are most informative, and how they should be interpreted in relation to one another rather than in isolation. For example, there may be value in examining genomic variation, epigenetic markers such as DNA methylation, inflammatory signatures, placental indicators, transcriptomic activity, maternal fetal hormonal patterns, metabolic signals, and measures of oxidative stress as part of an integrated developmental framework. A single marker may have limited explanatory power. A patterned constellation of markers, interpreted within maternal, placental, environmental, and clinical context, may prove far more useful. That point is crucial. Biomarkers without context can mislead. A technically measurable signal is not automatically a clinically meaningful one, nor is it inherently actionable. The future of this work, in my view, lies not merely in identifying more biomarkers, but in identifying the right biomarkers, embedded within a deeper framework of developmental biology, phenotype, equity, and longitudinal follow-up. We must ask not only whether a signal predicts risk, but what kind of risk, under what conditions, for whom, with what degree of confidence, and with what implications for care. This is where fetal development becomes especially important as a scientific and moral lens. Many of the conditions that burden children and adults may have roots in early biological adaptation. Neurodevelopmental differences, metabolic disease, cardiovascular vulnerability, immune dysregulation, and perhaps even certain cancers may not emerge from a single late event, but from layers of developmental influence accumulated over time. If so, then fetal biomarkers are not simply about pregnancy surveillance. They are about the developmental origins of lifelong health and disease. They may help explain how risk is biologically patterned before it becomes clinically visible. At the same time, this field demands humility. Early biomarkers can be powerful, but they also raise difficult questions. How do we distinguish elevated risk from deterministic prediction? How do we prevent biomarker science from becoming reductionistic, stigmatizing, or detached from social reality? How do we ensure that families are not burdened by information that is poorly explained, prematurely interpreted, or impossible to act upon? These questions matter profoundly, especially when we are dealing with fetuses, infants, and families navigating uncertainty. Scientific advancement must therefore be matched by careful attention to ethics, communication, and public trust. I would also strongly emphasize that early risk biomarker science must be developed in ways that do not replicate global inequities. Historically marginalized communities are often disproportionately exposed to the very conditions that may influence fetal development, including chronic stress, environmental hazards, nutritional inequity, limited access to prenatal care, undertreated maternal illness, and structural barriers within health systems. Yet these same communities are often underrepresented in the datasets that shape biomedical discovery. That imbalance is unacceptable. If biomarker science is to serve humanity, then the populations most burdened by preventable risk must not remain peripheral to the research enterprise. They must be meaningfully included in it. This is one reason I believe fetal biomarker research must be linked to maternal equity. We cannot meaningfully speak about fetal development while neglecting the health, safety, and lived conditions of the mother. The maternal body is not merely a background variable in fetal development. It is a primary environment. Maternal inflammation, hypertension, diabetes, nutritional status, mental health, infection, toxic exposure, and stress physiology all matter. Placental biology matters. Access to timely care matters. Respectful treatment in clinical settings matters. Therefore, an authentic early biomarker framework must be maternal-fetal in orientation, not fetal in abstraction. From a translational standpoint, the most useful biomarkers will likely be those that help guide practical decision-making. They may assist in identifying pregnancies that require closer surveillance, newborns who may benefit from earlier developmental evaluation, infants at higher risk for particular complications, or children who should receive preventive services sooner rather than later. They may also help refine public health strategy by revealing patterned biological effects of social adversity. In that sense, biomarkers could become not only tools of individualized care, but instruments of systems-level insight. Still, I believe the ultimate goal must remain human, not merely technical. The purpose of identifying early risk biomarkers is not to label children earlier. It is to protect them earlier. It is to reduce suffering, improve developmental opportunity, strengthen prevention, and increase the likelihood that each child will have a fair chance to live, grow, learn, and flourish. That is particularly urgent for children born into marginalized communities, where biological vulnerability is too often compounded by social disadvantage and delayed response. For these reasons, I view the study of early risk biomarkers and fetal development as deeply aligned with a life course model of medicine. It calls us to think beyond episodic care and beyond narrow disease categories. It asks us to examine the earliest biological beginnings of later outcomes. It encourages collaboration across neonatology, maternal fetal medicine, genetics, epigenetics, developmental biology, public health, bioinformatics, ethics, and health equity. And it reminds us that the earliest chapters of life may contain information powerful enough to transform the chapters that follow. In the end, the promise of this work is not simply that we may learn more about fetal biology. It is that we may begin to build a more anticipatory, compassionate, and just model of medicine. One that listens earlier, understands earlier, and acts earlier on behalf of children and families around the world. In closing, if we can recognize risk while life is still being formed, then we have a profound responsibility to use that knowledge to protect children before vulnerability becomes lifelong harm. In committed partnership to advance the health, well-being, achievement and life outcomes of children everywhere. Elevate every move.